Good morning, Dr. Patino here at the Cosmetic Surgical Center of El Cerrito. So we're gonna do micro air power assisted liposuction. This tool is like a toothbrush, right? In order to obtain a bloodless aspirate like this, there's many things that go into it, and I'm predicting that it's gonna be bloodless, right? Why? Because that's the way we do surgery here. I think I know it's a special, different technique, right? And I'm so confident that this is so predictable that I tell my patients, forget about my prior surgeries that are bloodless. Just watch tomorrow. So I got a whole bunch of people watching today's surgery, and I told them, look, if it's not bloodless, don't have surgery with me, okay? But what do you see there? Yeah, yeah. Can you see the output?
Beautiful output.
Yes, yellow.
Yellow fat.
Yellow, beautiful fat, right? And so that's basically the way it is. But also focus on my strokes, how slow they are, right? So it's also the same. If you get your toothbrush and you go right at it, there is gonna be bleeding for sure, right? On November 14th and 15th, where we're gonna teach how to put silicone implants through the belly button, and also how to do this very surgery, which is the fat transfer to the buttocks, right here at the Cosmetic Surgical Center of El Cerrito. So it starts with the patient, right? The patient doesn't take any aspirin, ibuprofen, herbs, vitamins, and the doctor doesn't give any of those vitamins or aspirin or ibuprofen or heparin-like medications like enoxaparin. And then the patient has to abstain from those medications and herbs and vitamins for at least 2 weeks before the procedure. The second thing that's very important is the tumescent anesthesia, right? So every doctor is familiar with the tumescent anesthesia, but not everybody does it, right? And so if you want to obtain this bloodless aspirate, you have to tumesce, and you have to tumesce properly in all levels, and you have to use plenty of tumescent anesthesia, right? And it's not so much the anesthetic, but it's the epinephrine that you put. You put 1 milligram of epinephrine, which is 1 ml, 1 in 1,000 epinephrine in each bottle of normal saline, right? So if you just use 1 liter for the belly and you start 5 minutes later, there is going to be bleeding, right? 1 liter for the back and start right away, there is going to be bleeding. So we do plenty of this tumescent anesthesia, yet we lower the dose of the numbing medicine, but we give more liters of it, right? So that, for example, in this level, right? Because this patient is also having general anesthetic. So all our patients in general have general anesthetic, or the great majority of our patients choose to have general anesthetic and also tumescent anesthesia. So that's the best of both worlds, because she's not going to feel anything during surgery, but post-operatively she's going to have much less pain. So you don't need to use anything than that. You don't need nerve blocks. You don't need Exparol. You don't need any of those things, as long as you do this properly, right? If you do this tumescent anesthesia, but you don't do it properly, and you don't do it in all levels, and you don't wait. We waited almost, did we wait an hour on this case? We usually wait a good hour before we even start, right? So from the time we put the tumescent anesthesia, look how yellow and beautiful that aspirate is, right? To the time that I start, it's a good hour. So if you don't have the time, if you're doing, 5 or 10 patients per day, well, yeah, you're probably not gonna have time to do all of these. But at the same time, we save time. Why? Because I don't have to wash this fat. This fat is what I want you to pay attention. This fat that's coming out is the exact same fat that's gonna go into her buttocks. So pay attention to how this yellow fat is gonna go into her buttocks. Thank you. All right, so not only does the patient get unstained fat into her buttocks that we don't even process, we don't have to spend time and money on any processing system, right? To process that fat that comes out red and clean it from all the red and oil from the broken fat cells, because aggressive liposuction with aggressive cannulas and the rapid motions of the surgeon break the fat cells and also the blood vessels and cause significant bleeding. And so when you put the fat graft into the buttocks, the way we do it is yellow is pure fat. So obviously the fat graft retention is going to be great, but if whatever you see going into the buttocks is red, that means that there is fat and blood mixed together, and obviously the blood is going to be reabsorbed, and then your buttocks are going to shrink. Of course there is, that effect even in our cases, but it's mostly because of the swelling. But in general, you lose 50 to 30% of whatever goes into your buttocks, but if on top of it you put a mixture of blood, I believe that accounts for the great majority of the fat loss that you lose, or the volume that you lose. So with this technique, not only do we not put any mixed blood in there, but it's pure fat. And also, the incredible thing is that this is very safe for the patient as well, because my strokes are very calculated. I go very, very slow, right? And so much less risk of an intra-abdominal or intrathoracic organ injury, right? Which we never had. But also many advantages, not only for the patient, but for the surgeon as well, because when you go slow like that, then you're less likely to get tired, and less risk of injuries to the surgeon himself as a result of repetitive motion, tendonitis, for example, shoulder pain or elbow pain or wrist pain, right? All that can be minimized, and especially because with this technique, because you go so slow, you can easily change hands, right? So switch hands, even if you're not ambidextrous, you can, do the liposuction with the other hand, so less risk. I think that those reported incidents of organ injury are usually happen on a Friday night on a very tired surgeon that's been at it on multiple cases and at full speed. And then, much like driving, when you're driving too fast, goes into an unintended area. And that's usually what happens. And thanks to God, we never had that, but doing the procedure slowly like this is much better. And you may think, well, that's going to take all day. And it actually doesn't, because we save time but not having to process that fast. So when we inject it into the buttocks, it's the same fat that's coming out is going back in, and you'll see it. Thank you. Alright, so right now I'm using my non-dominant hand, so even if you're not ambidextrous, you can do this procedure this way and avoid repetitive injury to your elbow or your shoulder or your wrist, prevent a tendinitis. So this is good for the patient, number one, because when you go slow like this, you have less risk of intra-abdominal or intrathoracic organ injury, something that has never happened to us. But it's because of, how calculated my strokes are and how slow we go. Even with the non-dominant hand, you see how my movements are slow, right? And so that only decreases the risk of intra-abdominal or intrathoracic organ injury, but it also, I believe, decreases the risk of damaging the adipocyte or the fat cell by aggressive cannulas and aggressive liposuction and the movement of the surgeon very, very fast. That destroys the fat cell, the oil leaks out of the fat cell, and that oil is rejected by the body, especially when you put it into the buttocks, for example, or the breast. When you put this fat, you create the famous oil cyst. something that we never have. I believe also that this plays a role also in the famous blowout fractures of the buttocks, which is like a light bulb that sticks out, like a ball that sticks out of the bottom. Usually that is the result of the surgeon disrupting the normal architecture of the buttocks, which we also do not do. But in addition, I believe that when you put something other than fat in there, say for example, or you put blood into the buttocks, so you can easily see if blood is going in, because whatever you put in there is going to turn, red, right? So if what you put in here is yellow, then you know it's yellow fat, right? And what surgeons typically do is that everything is red and then they wash it multiple times. They have a system that they buy, and then, but even then the fat is still red or pink. It's not like this, right? So when you see this patient, this is what's going to go into her buttocks, this beautiful yellow fat, unstained by blood and without any oil. There's no oil in there, so the body's not going to reject it. I think the body acts like it's rejected. It sees it as a foreign substance. Why? Because the blood is outside where it belongs. It's outside the blood vessel. So the body rejects it much like it would reject, let's say, a piece of glass or a bullet, and creates a callus around it and pushes it out into the superficial layers over time. And if you have an oil cyst, it's precisely that body creating a foreign body type-like reaction, similar to what happens when you have breast implants and the body creates a capsule around it. And one of the theories about capsular contracture, meaning that your implants become very hard, is precisely blood in there, a little bit of blood around that capsule that irritates the tissues, and the body reacts to it and forms an even greater scar, like say like a keloid inside. It starts compressing that implant and eventually may break it. Thank you. So we're almost done with high definition liposculpture of the abdomen on these patients. And what I'm doing now is I'm accentuating this umbilicus here, supra, above, umbilical, midline here. And have you noticed how there is like a line here and come from the top? You can see the line on the other side, right? You see that? So this side is already done. There's nothing here. This side already done. And now we're doing the midline here. And notice still that we're almost done with the surgery. Yes, look at the beautiful fat. Look at the beautiful yellow fat. So you can maintain this yellow output throughout the surgery. And that's what's incredible, right? That we do here at the Cosmetic Surgical Center of Rosarito. That we do bloodless surgery, right? So I say I drive, say for example, 45 miles an hour, right? And the way I do this surgery, right? I would say it's an estimate also that most surgeons drive about 75 miles an hour, right? It's also an estimate, it's not exact, it's an analogy, okay? And I say there's some surgeons that would go at 260 miles an hour. And you will see, in my case, every surgery that we do pretty much, no matter if it's an open, can you already see the definition of this lady? And we're almost done. Look at that, she looks almost, but still getting beautiful fat, right? Very beautiful fat, right?
Almost done with the high def. We still got the back to do, right?
Oh, we still got to do the back, but we're going to do a high def on the back as well.
Ooh.
But I'm just showing you the output, right? It's yellow, beautiful output, right?
Yeah.
So that's what we want to see. You see this yellow output, right?
Yeah.
Toward the end of the case, that's very important, right? And we're going to do the same on this other side, see? So she looks very athletic already. And that's the way we like to do it, right? Here at the Cosmetic Surgical Center of Rosarito. Thank you. Again, I'm using my non-dominant hand. And the patient is now on the lateral decubitus, meaning she's on her side. And notice the complete absence of bleeding. It remains to have this beautiful yellow fat, pure fat output, right? not stained by blood and without any oil. But my strokes are very calculated, very slow, and so that makes the whole procedure better, right? And it's good for the surgeon. The surgeon is not sweating it, you know, and it's not going very fast. It's very controlled procedure. And that's the way we do all the procedures here at the Cosmetic Surgical Center of Toledo. We take our time. I'm gonna give her a very nice waist over here. And I'm pinching the area. Look at all these spots that she has, right? And we're gonna, you know,
Get rid of it.
get rid of it. Yeah, you got it. Like, look at the difference. See, this is the pinch here. That area is not done, right? And let me show you the pinch on this area that's done. See, this is the belly. And look at this, for example. See, see the difference?
Nothing.
There's nothing here, but look at this over here. You see?
Yep.
Nothing here, look at this. Big, big, big. Thank you. Look how comfortable I am doing this procedure. And I can literally grab it with 2 fingers. It just slides there. There's no tension, and so very effortless surgery for me. Much less risk of perforating an internal organ, of course, because like I said, it's like driving a car at slow speed, right? I think what happens is that when those things happen, and it never happened to us, thanks to God, but when those things happen, usually happen on a Friday night, you know, after a surgeon is already tired from doing many cases during the day and throughout the week, right? And is going at full speed, you know, and it goes into unintended areas, pretty much like what would happen to you if you're on the freeway speeding at very high speed. You may lose control of the vehicle and go into an unintended area. But I contend that it's almost very difficult for me to do that at this speed and so controlled. And I'm not sweating it, you know. And we just do 1 case or 2 at the most a day. So if you're doing 10, 13 cases a day, which some surgeons do, you know, well, you know, you gotta do it fast, and you gotta also have other assistants do the surgery. No one surgeon can do all the surgery by himself, so he would have to rely on other assistants. Oftentimes not surgeons do the procedure. I stay with my patient throughout the entire procedure. And so as a result, you know, we can obtain this beautiful aspirate. The patients don't bleed. If they don't bleed, then they have no anemia. If they don't have anemia, they're not weak the next day. If they're not weak the next day, they can walk. If they can walk, they can prevent a blood clot. A blood clot is the one thing that can... Yeah, another very unique thing is that the amount of tumescent anesthesia that I put here is significant, yet the toxicity is very low. We never had a case of toxicity from the anesthesia. We keep it at basically half the maximum dose. You know, the maximum dose can go up to 55 milligrams per kilo. We never go over 28 milligrams per kilo, and usually we're below even that. So in this particular case, we're below that. So much less risk, right? Now, the beauty of this is that I just started publishing on TikTok about 6 months ago, and some of the people there don't know me, I guess, and they say, no way that he can do surgery like this, impossible. Impossible. I was in severe pain and I got Exparel, which is a long-lasting numbing medicine, and a nerve block, and I say, yeah, but you know, they're not using my technique, so it's different,
It's
right?
different.
If you wanna like this, you know,
You gotta come here.
Yeah, come here, or you know, I'm teaching other doctors also on November 14th and 15th. I'm teaching how to do also the transumbilical silicone breast augmentation, which is a world discovery. I think you guys should be asking for this procedure so it doesn't die with me, you know. I want other doctors to learn, and will be happy to teach them because it has many advantages to you. I want to teach this technique also to other doctors, and we do that here at the Cosmetic Surgical Center of El Cerrito. Thank you. So that's her waist. Buttocks over here. She's on her side. Notice the nice waist, right? And this is the what we call the pinch test. This is part of the surgery. But notice how there's absolutely no excess fat anywhere we go. So this is down to nothing here. Everywhere is like this. You see that? Incredible. So very nice. Thank you. All right. So just if you're wondering, what we're doing, we're almost done. We probably have like a half an hour. She's on the other side, and notice the output still remains beautiful yellow fat, right? And now I'm going with my dominant hand, but still I go very slow, right? And very controlled movement. So very safe for the patient, very safe for the surgeon as well. Yeah, it's less likely that the surgeon would get repetitive motion injuries like tendinitis, right? Elbow, tennis, and shoulder problems and wrist problems. I don't do it for that reason. I do it mostly for the patient so that I'm not speeding. I compare these to like, driving a car. If I'm going 260 miles an hour, man, wow, that's a professional racer. But when those cars flip, man, sometimes they die, right? And so we never had anybody die. And we don't want to be flipping over here, man. We want to just do a very good job, slowly take my time. I think the only reason to go fast is to make more money and do more patients, honestly. There is no other reason, because the timing in our surgeries is still extremely efficient. It's just the normal time that you would spend, We're almost done with the procedure, so this is, as long as you're like under 4 hours, you're good, Thank you. Wow, so look at her lower back. So I sculpted this area so to define the paravertebral muscles. Can you see the lines here on either side?
Yes.
And we're gonna do the fat transfer to the buttocks now. Thank you.
Okay.
Alright, so this is ultrasound guided gluteal fat transfer, meaning that we're gonna do this under ultrasound guidance, right? So notice the yellow fat, and I'm looking at the screen. And I'm looking at the patient to make sure that we put this in the right place, right? But look at this, it's incredible. How we do this under ultrasound guidance. We're teaching these courses through the World Association of Gluteal Surgeons. We have a workshop here at the Cosmetic Surgery coming up on November 14 and 15, 2024. We're teaching surgeons how to put the fat graft in the deep subcutaneous space where God put it, and not into the muscle or under the muscle for much more safety. Our president, Dr. Alexander Earl, presented a study with 0 death under ultrasound guidance through the World Association of Gluteal Surgeons. And I never had anybody die either, thanks to God. And we do ultrasound. We were some of the pioneers in this field doing this under ultrasound guidance. Thank you. Wow, look at this fat. It's pure fat. We have not treated this fat in any way whatsoever. It's incredible. Thank you. Yeah, and Gabby, what were you saying?
We don't use the TSA for the
oh yeah, exactly. Yeah, so we don't use any heparin, we don't use any aspirin-like medications, we don't use TXA, which is tranexamic acid. Some doctors use it and it decreases significantly the amount of bleeding, but we don't need it because it's not going to get better than this yellow fat, right? So we tried it before, but it didn't change for us. But I know it's very important. I know it changes for other doctors to the point that they don't have to use the cell saver anymore. But for us, it doesn't make any difference because we get bloodless aspirated to begin with. This fat has not been treated in any way. And I go in by 100s, right? So I get 100 and then I move to the other side and then I go in the intergluteal incision, right? So right now, I'm gonna go in the intergluteal incision. And this is very important because right here is where the gluteal vessels are, right? So I'm looking at the ultrasound, but I'm gonna show you something here. for the doctors watching out there. I put my one finger here in the coccyx, another one in the posterior superior iliac spine, and the one in the middle, that's where the vessels are. So right there in that area, but I'm going superficial to the vessels, right? And you can see it under ultrasound. We're going to show you under ultrasound how we do this. Thank you.
This right here is the patient's skin, and all of this is the patient's muscle. It's striated. You can see the stripes that go from one side to the other. If you put the fat there, that's where the patient could die. So right here, between the deep gluteal fascia and the superficial gluteal fascia, which has a branch right here, so you see part of it right there, part of it right there. This is the subcutaneous space where Dr. Patino can actually put the fat, and this is Dr. Patino's cannula right here. The point is around this side. So
I'm going to wiggle it so you can see it, okay? And I'm going to withdraw it a little bit.
Yeah.
And then you can see the edge. Do you see the end of the cannula?
Yeah.
Okay, focus your eyes right there because I'm going to give it a bolus and then you'll describe what happens. 1, 2, 3, go.
All right, so we have fat entering this space, and you can see already that there's some bending here at the deep gluteal fascia as it gets the pressure from the fat entering the space, pushing it down and pushing up on the superficial gluteal fascia. And all this gray right here, that's the fat that's entering the space.
And that's my cannula right there. I'm going to give it another bolus right there. Right.
So see the gray cloud right there, that's fat.
And how the muscle pushed down and the superficial gluteal fascia was pushed up.
Yep.
And the vessels are way deep into the muscle. So we're in a safe area. Thank you.